Now, the next topic, the big topic, is the GI, or the pathophysiology of the gastrointestinal tract. Now, what can be the most common symptoms of a patient who has some GI problem? Mostly the patient, they do have leading symptoms that can be associated with different diseases. This kind of list is, is listed from the most common one to relatively the last one. Very much of you, or very much of us, usually have the GERD, or gastroesophageal reflux diseases, that is manifested usually with the symptoms of heartburn, when the patient feels some retrosternal pain, or bleaching, dysphagia, or regurgitation, or they do have some teeth erosion, or the peptic ulcer, another one. Today is less and less common. A long time ago, it was a very big problem with the patient because the treatment wasn't so easy. And mostly they operated or removed the stomach for the patient. And this is manifested as a postprandial epigastric pain, or hematemesis, or tar-like or very dark stool. Pancreatitis today is still confined, acute or chronic one, that usually associated with the chronic one, mainly malabsorption, and the acute one that can be an acute inflammatory processes that can be manifested, such as, for example, a shock, hypovolemic shock, can be manifested as an acute belly, sub a defense mechanism, and from the peritonitis, so the all pain with the peritonitis, this epigastric pain that radiating toward the back, for example, or a periumbilical area. GI infection relatively is very, very common one that mostly is presented as a diarrhea that can be bloody, but vomiting or abdominal pain can be the symptoms as well. Malabsorption, mostly diarrhea because the bacteria overgrow and can form soft feces and can increase the motility of the GI tract, and weight loss because we cannot absorb the energy. Or inflammatory bowel diseases such as the colitis ulcerosa or Crohn's diseases, abdominal pain, the mucus, bloody feces, diarrhea. And GI tumors are the important aspect of the GI diseases that can be as a dysphagia, weight loss, GI bleeding, usually is occult or chronic, very low grade bleeding can be, or change of the stool habit that can be obstipation changed by the diarrhea, and mechanical ileus can develop in this patient because the tumor is obliterating the GI tract. So this all can be the symptoms. Now, let's start with the diarrhea because that can be a very important leading symptoms, a very common symptoms of a patient. Mostly this is associated with some kind of infection. It's very common one, the viral infection. Rotavirus or enterovirus and hepatitis can be manifested with diarrhea. But bacteria, you will learn in microbiology, the E. coli, Salmonella, Shigella, or Clostridium difficile, or Campylobacter, or parasite, Giardiasis, or amoebiasis can cause diarrhea, and this can be treated properly. So in this case, these feces should be evaluated by microbiological tests. The food allergy is another important one because somebody is allergic to food. Not only, let's see, the peanut, but for example, the seafoods and other can cause diarrhea or can cause a more severe allergic symptoms as well. But food poisoning, such as the enterotoxic of the audeus, for example, or coli, or perfing gas, or anything that can cause a problem with the patient and cause diarrhea, or fungi, or heavy metal poisoning, or dyspepsia, if somebody has lactose intolerance, or pancreas exocrine disturbance, for example, or celiac diseases, the gluten sensitivity, or enteropathia, or irritable bowel syndrome, or inflammatory bowel diseases, as we mentioned before, a tumor, and whoever has tuberculosis or intestine infection or short gut syndromes, for example, or gallbladder resection due to the surgical operation, hormones in thyroxine, hyperthyroidism, or epinephrine, pheochromocytoma, or Zollinger-Ellison syndrome when we do have an elevated of the gastric level, or carcinoid tumor can cause diarrhea. A diabetes mellitus when we do have an autonomic nephropathy and autonomic disturbances, and certain drugs can cause diarrhea. Now, these are the summary of that what could be searched in a case if the patient presented with diarrhea, and usually long-standing diarrhea. Now, what will happen in other case when we do have this GERD, that's the gastro-esophageal reflux diseases? What will happen? In this case, the problem is we do have an esophageal sphincter abnormality, and this is why the regurgitation of the stomach content to the esophagus can detect it. If the cardia is not causing properly, or the diaphragmatic hernia the patient has and doesn't have, let's say, the closed the cardia, that can cause GERD. If somebody has an acid overproduction, and other risk factor, if they do have, for example, H. pylori infection, again, that can lead to this regurgitation of acid substance in the esophageal. Obesity is a very high risk for GERD, because if your stomach is too much, is pushing up, let's say, this the stomach, and this can cause a regurgitation. Pregnancy, usually in the third trimester, again, that can cause GERD syndromes. Or if somebody eating too much and laying down early after eating, again, that can cause GERD. Now, what can be the symptoms of this GERD, such as, for example, heartburn, that you can have an epigastrial pain. And this severe heartburn sometimes can mimic or can cause by a myocardial MI, usually the inferior myocardial MI as well. So this should be, let's see, differentiated from each other. And very commonly, dysphagia or acid bleaching can occur in this patient who has this GERD. Always, if we do deal with the GI tract, the first examination should be endoscopy. Endoscopy performed, and that you can visualize the system, plus you can take biopsy from those areas that you do see some inflammation. Another thing, manometry, it is less precisely measuring what they measure, basically how much pressure is needed to open up the cardia. But in some, for example, center, they are not going to perform this manometry. And barium swallowing X-ray evaluation is a long time story, so they are stopped doing this one. The complication, what could be the complication if we do have all the time the regurgitation of the acid substances in the esophagus? This can maintain an inflammation, and repeated inflammation can cause erosion, ulcer, and stricture. And finally, that can develop a Barrett esophagus, and that means a precancerosus case. And as esophageal cancer can develop, this is why we have to take seriously. What treatment we need for the GERD? Basically, the lifetime changes. Don't eat too much. Don't eat those food that increases the acid production too much. Or don't lay into the bed, let's see, early after eating. Don't drink gassed, for example, alcohol, because alcohol can induce the acid secretion and can dilate the sphincter. So let's stop this. Another one, the eradication of the H. pylori, if there are, because H. pylori can increase the acid production of the stomach. And by eradicating this H. pylori, you can somehow cure the GERD. Now, this is the manometry, what is happening. This is measuring the pH in the esophagus. And as you see here in GERD, when you do have a regurgitation of the acid, that's the pH is decreases. And in the pharynx, for example, this is the pharynx, the pressure value. This is very high, should be very high when it's opening up. However, if somebody has a GERD, It's very easy to open up. And these all showing that you do have an abnormal sphincter function, but it's very rare clinic they are measuring this kind of manometric evaluation. The peptic ulcer is another big diseases that usually is manifested as a pain that usually as epigastric pain usually associated with eating. That can happen right after eating or depending what kind of food you are ingesting. If you are ingesting alcohol or salicylic acid plus alcohol, that can cause a severe epigastric pain and vomiting, nausea, or dyspepsia, and chronic bleaching, chronic bleeding that can lead to anemia, because this bleeding can occur in the upper GI tract, not only from the lower GI tract. And because it's acidic milieu, this is why in the stool, if you do have a larger amount of blood that you are losing, that's be the tar-like stool. Now, again, what we do for evaluation, gastroscopy or endoscopic evaluation, and today's that we do the H. pylori detection. That's very, very important. Long time ago, we had no idea what caused the peptic ulcer, and we believe that somehow the aggressive and defensive factors are altered, and that or the defensive be less. For example, if you are taking aspirin, blocking the PGE2, PGI2, so and altering the mucus production or the bicarbonate production, and that could be the problem. But after a doctor who had an idea that possibly the bacteria could be correlated with the GI tract ulcer, that everybody knew that in the GI, in the stomach, we found H. pylori, that the bacteria that control the acid milieu. And what they believe, that's a regular bacteria that can be found in the stomach because these bacteria tolerate the acid milieu. And this doctor, what he did, basically he inoculated himself with this bacteria and proved with endoscopy that yes, this bacteria infection was the, let's see, the cause of the peptic ulcer that he developed. And after using the antibiotic therapy, he cured himself and proved that, yes, see, the peptic ulcer disappeared when I eradicated the H. pylori. So this is how was the new area for the treatment of the peptic ulcer. And before they did not do anything, what they did, they used some antacids, for example, proton pump inhibitors, and if it's needed, they perform a resection of the stomach. This is a Bayreuth 1, Bayreuth 2. You will hear about the surgical courses. But today it's relatively easy to treat it. Let's check for the H. pylori, and if you do find, let's eradicate the H. pylori, and after everything goes back to the normal. And as you see here, the treatment, lifetime change, inhibition of H. pylori, and eradication of the H. pylori. This is the main treatment now, the peptic ulcer. The problem with this peptic ulceration, if this is a long-standing inflammation of ulceration, that can lead to the stomach cancer development. Now, what about this H. pylori? You are going to hear about in microbiology, but this is connected to possible to the ulcer formation, both in stomach and the duodenum. That can cause atrophia of the gastric area, so gastritis and stomach cancer, and lymphoma is correlated with this H. pylori, the bacteria itself. The identification of this H. pylori, that can be invasive. Usually what they do, during the endoscope or gastroscope, they are taking samples and they are using the microbiological test for the H. pylori. But it can be used, for example, the urea exhalation test. As urea exhalation test means that you are giving urea to the patient, and this bacteria has a urease activity, and usually they are going to cleave or digest the urea, using up the urea, and you can measure the carbon dioxide that is exhaled, and this is in the air, in the breath, can be detected, and that's a proof that the bacteria is present in the gastric milieu. Now, what is the urease activity for? Now, this urease activity that is going to protect the bacteria, because that urease is going to produce ammonia and ammonium as well. So that's a more alkalic milieu. And this alkalic milieu is protecting the bacteria. However, this alkalic milieu can decrease the pH locally in the antrum, and this decrease of the pH is going to induce the gastrin secretion. So this patient has an increased gastrin and increased acid production. So this is how this H. pylori is going to increase the acidity. However, this bacteria has some kind of toxins that can cause necrosis of the gastric mucosa. Another thing how they can measure it, for example, serology, the H. pylori IgG test. This H. pylori IgG test can be measured, for example, the feces, but is directly doesn't show exactly that the patient is still having this infection or not. And in the blood, when you measure the IgG, only means that the patient already survived this one or already have it. We don't know exactly. So this kind of test can be performed as well. The antrum biopsy, as I mentioned, and the cultivation, that's another direct proof for this bacteria infection. And this is what the urease test means. You can detect it right here. Now, this is how they looks like. There's the little staining with the bacteria. You can see it here or here, how they look like this H. pylori. Now, the continuation with this acid secretion, that's a hypergastrinemia when the gastrin level is high, and this is why we do have an increased acid production and increased chance to have the peptic ulcer. Now, the causes of the hypergastrinemia, such as the gastrinoma, when we do have a tumor relatively that is going to secrete the gastrin, such as the Zollinger-Ellison syndromes, or a part of the multiple endocrine neoplasia, this all can cause an increase of the gastrin level. What they test, they are measuring the secretin, usually the secretin test, giving secretin and measuring the gastrin production. How high is this one? But antrum G cell hyperplasia is a very rare one. You don't need to know about it. And serum gastrin level is a slightly higher one. And usually in this case, we do have a secretin test is negative. Now, what will be, let's see, and when you are suspicious about the hypergastrinemia? If the patient has a severe ulcer complication, usually recurrent ulcers or multiple ulcers with diarrhea or atypical localization, severe reflux, such as very severe GERD, and chronic GERD, and some other sign of the endocrine disorders, such as, for example, parathyroid hormone level, thyroxine hormone level, and growth hormone level can be associated with this one. Now, the secretin test determine the basal gastrin level, and after give some IV and secretin, and this is how you're measuring how big the gastrin level be. Now, repeated acute gastritis chronically can lead to atrophic gastritis. Now, that's very important because atrophic gastritis can lead to tumor and can cause some malabsorption. Now, in the etiology, as you see here, mostly the H. pylori infection, the chronic H. pylori infection can be, or some autoimmunity. The symptoms such can be some dyspepsia, because if you don't have any acidity, the protein degradation be abnormal one, or pernicious anemia can develop, the B12 absorption be abnormal because there is no intrinsic factor. So megaloblastic anemia or neuropsychiatric disorders can develop because the B12 can be correlated with the myelin synthesis, and they do have some neurological symptoms as well. And as I mentioned, the atrophic gastritis can lead to the stomach carcinoma. And this is why whoever has a chronic atrophic gastritis, but they need a continuous control. Now, what kind of antibodies can be detected in this case when we do have an autoimmune mediated atrophic gastritis? There are the parietal cells antibody that can be detected, for example, or the intrinsic factor antibody. These are the two antibodies that can be tested in atrophic gastritis. The Schilling test is not used today. They are evaluating the B12 absorption. And this test is performed if the patient has a megaloblastic anemia. We are going to talk about in the next semester. And you want to see whether this B12 absorption is due to an abnormal milieu in the stomach. For example, you don't have intrinsic factor, or you do have some additional problem. And these tests, what they use, they are giving first unlabeled parenterally B12, and after isotope B12 is given orally and measuring in the urine, the urinated labeled B12, because you saturated by the parenteral administration of B12, there is no stored B12 occurs in the body, and everything should be urinated out. And however, if this urination or excretion is less than 14%, the next you are giving intrinsic factor. And if the intrinsic factor normalizes the absorption, now that's the diagnosis for the pernicious anemia. So that intrinsic factor abnormality causes the diseases. Now, in the first case, we do have a 73-year-old man smoking daily, alcohol occasionally, and takes NSAID, non-steroidal anti-inflammatory drugs. Now, last week he had liquid stool, so diarrhea 3 to 4 times per day, might have been bloody as well. Today he observed tar-like stool, so it's meaning that these blood should come from the upper tract, melena, and vague epigastric pain. Otherwise, negative status. He had no fever, nausea, or vomiting. Notice sclera and the conjunctiva were pale, meaning anemia. So this patient had anemia. Look at the lab values. The white blood cell count is very high. The red blood cell count is low, so it has anemia. The hemoglobin is lower one. It should be higher than 120. The hematocrit is lower one, and the platelet count is higher one. Okay, let's go on. Gastroscopy showed a moderate amount of fresh blood in the stomach. Peristaltic function preserved. Kerning waves are normal. Mucous membrane of the bowel is edematosus. On the ventral wall, 1 centimeter size superficial ulcer is found, which is slightly bleeding. So it's some kind of gastric bleeding the patient had. Now this is the endoscopic evaluation. That should be the normal on the right side. And here you do see the peptic ulceration that occurs at the bleeding, the continuous bleeding of the patient. So first of all, what can we do? First, control the bleeding, and that can be done during the endoscopic evaluation, usually by injecting in this area with epinephrine or using a clip, okay? And the lifestyle change, okay, the NSAID should be discontinued and stop smoking. And of course, there is no alcohol at least. And some inhibitors, for example, the acid secretion, so the proton pump inhibitors that they are using. Now, when they use antacids, you know that they're going to bind the acid. That's good and bad because it's going to absorb the acid in the stomach. However, when it's emptied, when it's passing through into the duodenum, in the stomach, we do have a rebound effect because the alkalic and the milieu, the pH milieu be lower when you are taking antacids. That's going to stimulate the gastrin secretion, and the patient could have an elevated acid secretion after that. This is why now they give proton pump inhibitor mostly and not antacids to solve the problem of the patient. Acute pancreatitis. Now, this is another big chunk or the better big problem in internal medicine or in the clinic. First of all, there are several types of acute pancreatitis, I mean clinically. I think that's the mildest form that everybody could have or already had some acute pancreatitis when you eat too much or you ate too much food and the next day you lost your appetite, you had a little bit of diarrhea, you had an odorated feces, and you didn't have any appetite, so you didn't eat for one day, and after everything back to the normal. So that can be the very mild form of acute pancreatitis. The next type of the acute pancreatitis, when this inflammation be so severe one, the fluid sequestration happening in the GI, in the abdominal cavity, and hypovolemia leading to the circulatory shock, and the patient is taken to the internal medicine. This is the second type, and usually this is the most common one. However, the worst situation when we do have a necrotized one. So this was the cirrhotic type, and the necrotized type, when we do have a necrosis and can cause a complete inflammatory reaction of the abdomen, and this can develop a defense mechanism, and that's necrotized type. Usually the patient is taken to the surgeon, and very rare can survive this situation. So this is the three different types of acute pancreatitis. And what is the essential with acute pancreatitis? The pancreas itself is going to digest the tissues in total. Now, what can cause this? The very common cause, there are three: alcohol, bile stone. The best one, if you drink a lot of alcohol and eating fatty food. If you remember what alcohol does with lipoprotein lipase, inhibits it. So this way we do have an increased chylomicron level after eating too much fat. And this huge big chylomicron is going to obliterate the capillaries and can cause a local necrosis in the pancreatic tissue, and that can cause an autodigestion of the pancreas. Bile stone is similar one, because bile stone, when it's obliterating the bile duct, and some bile can regurgitate into the pancreas, and this disintegration can happen with the tissues and activation of the enzyme. So this is again what the pancreas, acute pancreatitis can develop. Another one, viral infection, trauma, and hypercalcemia again can lead to acute pancreatitis, but less commonly. However, if somebody has a type 1 hyperlipidemia in a chylomicronemia, this is the first how it's manifested. A small boy or girl, usually age of 7 or 8, they do have acute pancreatitis, and after they are figuring out that this is due to the hyperlipidemias. No, the symptoms usually it's accompanied with abdominal pain, with a bat-like pain, nausea, vomiting, fever. And this is what I mentioned, that can be the oedematosus or cirrhosis or interstitial one, about 80%. And the necrotizing, when we do have peritonitis, that takes about 20%, and that's very severe condition and usually lethal one. Now, what can we do? The problem that this enzyme, this exocrine enzyme, getting back to the blood circulation due to the necrosis. So what we do have, we measure the enzyme level in the blood, lipase, amylase, and inflammatory markers such as a CRP, for example, can be measured. And of course, the first one, ultrasound and CT should be taken to see how the pancreas tissue looks like. Usually swallowed, and the structure is altered and then diffusely altered. What will be the complication? The complication, the first acute complication can be the circulatory shock due to the hypovolemia, due to the redistribution. Now, in longer term, that abscess or fistulas can develop, and the pseudocyst formation can happen. And in later on, usually the exocrine function or endocrine function can be altered, but usually that's associated with chronic pancreatitis. What we should do immediately, supportive therapy, IV fluid supplementation to counteract with the hypovolemia, pain relief, and total fasting. There is no way that a patient can take food orally. Usually jejunal nutrition is needed, and antibiotic especially in necrotizing type. So the shock treatment is essential one, and the surgical intervention should be needed if the patient had, for example, cholelithiasis, or the patient had necrotizing type of pancreatitis. Immediately you have to resect and have to remove this necrotized tissue. Let's see the case when we have here a 46-year-old man that, let's see the anamnesis, chronic alcoholism. Past year, he has been drinking a bottle of hard drink daily. And yesterday, he had a greasy dinner. He also drank 4 vodka shots, a number of spritzers as well. Today, very strong epigastric pain developed. He is constantly sweating, has fever, and he's often retching, but has not vomited. Stool regularly, no bleeding, no black discoloration, and no mucus or no tarry stool-like. Okay, abdomen is above the level of the chest, a bit stiffer, distended, but can be palpable, so it's not a defense at all. Epigastrium is filled. Abnormal resistance is not palpable. There is a diffuse abdominal tenderness. Its maximum is above the epigastrium. Intestine are meteoristic. Blood pressure is lower, or it's okay, and the heart rate is a little bit maybe higher for this guy, but it still has to consider as a normal one, has to be considered. Now at admission, his significant laboratory abnormalities, the serum CRP level is elevated a little bit, serum amylase level is elevated, serum urea level is elevated, and creatinine is elevated. Now, serum urea and creatinine can be elevated due to the kidney abnormality, but it can be elevated due to a shock compensation, because the kidney is locked out from the circulation due to the redistribution of the blood flow. The kidney has about 20% of blood flow, and this almost can be shut down completely. And if you do have less blood to the kidney, what it will have, that the patient relatively has an accumulation of the urea and the creatinine. They did the CT scan and they found dilated edematosus pancreas, and reactive lymph nodes can be observed in a neighboring, and inflammatory area is about 10 centimeters in size and infiltrates the fat tissue, the surrounding fat tissues as well, and free abdominal fluid is not visible, no sign of necrosis. So the opinion is pancreatitis acuta interstitialis. Now, what they did, intravenous fluid administration to cure, let's say, the hypovolemia, no food orally, jejunal nutrition only, and pain relief is required. Later on, they measured the CRP. And as you remember, that the CRP was about 14. And now the patient CRP increased to 333. Plus, the calcium level decreased and the LDH level increased. And this meaning that this pancreatitis is advanced and now possible just a necrotized type. On the third day, CRP increased further, and that's again propagation of inflammation means. Cardiorespiratory instability developed, and renal function parameters worsened, and the urea is increased very much, and the creatinine increased very much, which indicate multi-organ failure. So the patient was transferred to the intensive care unit. So the pancreas is enlarged with the CT. There is no more contrast material accumulation in the pancreas. Fat tissue infiltrated around the pancreas. Air pocket can be seen, indicating necrotized areas. The large amount of free fluid can be seen in the abdomen. So that's an extended necrotous type of pancreatitis is diagnosed right now. What they can do, well, nephrectomy, opening up and rinsing with the abscess in the abdominal cavity. And a complete surgical remedy wasn't possible because of the great extending inflammation and necrosis all of the abdominal cavity, even some of the retroperitoneal walls affected. Later, the condition of the patient became unstable and he died because of the cardiorespiratory failure. So the necrotized type, about 70% of the cases, is leading to death of this patient. Now, chronic pancreatitis that can be developed when we do have a repeated acute pancreatitis is most commonly due to alcoholism, because alcohol can cause repeated acute pancreatitis and later on, after decades or 2-3 decades, causes chronic pancreatitis. But autoimmune is another large problem with this chronic pancreatitis. The symptoms usually is due to the absorptional problem. Now, the patient has chronic abdominal pain, sometimes is acutely exacerbated, food stool steatorrhea because there is now lipid absorption and the feces be sticky and is a lipid or shiny surface with a shiny surface, and weight loss because nor energy nor protein can be absorbed. So what we do have in a lab, the enzymes such as amylase, lipase, in acute phase, it increases in the blood. However, when we do not have any acute exacerbation of the pancreatitis, usually this enzyme level is lower than the normal. In CT or ultrasound or MRI, we do see an enlargement of the pancreas, can be edema or calcification or abscesses or pseudocystis. Why the pancreas enlarging? Because the fibrotic tissue replacing the pancreatic tissue. And in the stool, we do have a lot of fatty stool, so steatorrhea can happen. Now, functionally tests that can measure usually the enzyme that is liberated out. This is a Lindl test and another test I think we are talking to a little bit later on. The complication of the pseudocyst or abscess can develop narrowing of the bile duct or the exocrine function decreases. So this is a mild digestion and usually diabetes mellitus due to the beta cell destruction. What the treatment, alcohol withdrawal, if it could be, and supplementation of exocrine enzymes. So you can take pills that has the pancreatic enzyme in it. Now the direct test of the pancreatic function, first of all, as we mentioned, that the fatty stool, that's the steatorrhea, it was more than 7 grams, or the presence of enzyme in the stool. Now what they're measuring, mostly they measure the elastase activity because elastase is not cleaved during the passage in the stool. Chymotrypsin, trypsin, amylase is not good because these enzymes degraded during the passage. So as you know that every pancreatic enzyme synthesized in a pro-enzyme form, and after they are going to cleave each other and make them active. So this is why only the elastase is good because elastase produced proportionate to the enzyme, but is not degraded during the digestive process. Now, some other directive functional tests, what they use, usually they put an endoscope and they are collecting the pancreatic juice and they are stimulating the pancreatic function, such as, for example, giving them secretin cholecystokinin, or pancreatural test. These are those tests that they can use in chronic pancreatitis. Now, steatorrhea, I already mentioned that when we do have too much fat, the fat is not degraded and absorbed in the intestine, and macroscopy, the stool is bright and shiny and sticking on the faience, and often associated with smelling. Usually this is the protein that it smells a lot, and usually the amount of stool is bigger if you are not digesting one. Now, this steatorrhea can be due to not only due to the chronic pancreatitis or pancreatic disorders, but if you don't have, for example, bile, this is one thing, or the pH change as well. So this or malabsorption, if you do have the absorption surface is altered for some reason. So these all can lead to steatorrhea. So not only the chronic pancreatitis lead to steatorrhea. As I mentioned, the elastase is equimolarly synthesized in pancreas and not digested. So this is why it's a good substance to measure to evaluate the secreted enzyme or by the pancreas. Now, malabsorption, that's a secreting cholecystones test, as I mentioned. They give IV secreting cholecystones, and they are collecting the duodenal fluid, and they're measuring the amount of enzyme. And the pancreatic test, this is a fluorescein test they're giving orally, and they're measuring in the urine the fluorescein content of the, usually this is the lipase activity is measured by this test, and it's a fluorescein material that's a water soluble, and this can be measured in the urine. Usually what they use these two tests, cholecystokinin and pancreatic test, to measure the reserve capacity of the pancreas, so how much extra enzyme should be given to the patient to normalize the absorption. Okay, malabsorption still causes about more than 40% of the cases infection, celiac disease, IBD, the immune bowel diseases, lactose intolerance, and endocrine disease such as the hyperthyroidism and enzyme deficiency. So this takes about, the red one takes about 40% of the all. The syndromes be diarrhea because the back end, the fluctuation, the gas formation, because the bacteria is going to cleave or utilize this and metabolize and unabsorbed food component, and this is why the patient has this problem. The diagnostic test is stool culture, the microbiological culture. You can measure the concentration of the serum iron, calcium, albumin, cholesterol, so what's going to be absorbed from the intestine, and breath test, hydrogen breath test, and D-xylose test. A D-xylose test is measuring directly the absorptional ability of the mucosa of the GI tract, and the hydrogen breath test measuring the bacterial production or bacterial presence in the GI tract. Now, the lactose intolerance, another relatively common disorders, it meaning that in the brushboard enzyme, or what is the lactase, is not present, or the activity is suppressed. When we were born, relatively we do have a lactase activity, but after this lactase enzyme expression is suppressed, so this way we cannot tolerate any milk or any lactose. And that is because the bacteria can utilize, let's see, the lactose, making gas formation and making, let's see, the stool fluid, and that's diarrhea can occur. So this is how it's manifested with this patient. Now, what kind of test we can use? And this is the hydrogen breath test. Now, during the bacterial effect, what the bacteria does from the sugar, they are going to ferment the lactose. And what it does, making methane and making hydrogen. And in the exhaled air, we can measure the hydrogen ion concentration. So what we do, we give lactose to the patient orally. And normally they are measuring subsequently in 10 minutes, 20 minutes, or 1 hour, the hydrogen in the breath. Normally there is no bacteria in the small intestine, and this is why what will happen if it's absorbed, so relatively from the colon, there is no lactose at all. So the bacteria cannot ferment it. However, if we are missing the lactase enzyme, so the lactose gets into the colon when we do have the bacteria, and a lot of hydrogen can be measured in the exhaled air. This is the lactose intolerance testing. Sometimes they give alcohol to the lactose because alcohol inhibits the brush border enzyme. So in some patients, this enzyme activity is not zero, but less than a normal one. I think a lot of you sense that you could drink, for example, 1 glass of milk, but you cannot drink 1 liter of milk because after you do have a little diarrhea maybe or discomfort or gas formation. Another test, and that's the lactulose and dextrose or lactulose and glucose test, when they measuring the bacterial contamination of the small intestine. Now, lactulose cannot be utilized by us because there is no enzyme that can cleave the lactulose. So if the bacteria is invaded into the small intestine, the lactulose utilized and a hydrogen can be detected right after the injection, maybe 10 minutes or 20 minutes or so. The glucose, we can utilize the glucose and there's no problem about. So this is how we can evaluate whether we do have enzyme defect or we do have a bacteria contamination in the small intestine. So these are the tests. Now, isotope studies are not very wide use methods, but we are using usually the stable isotope of the carbon, and we are measuring the C13 isotope. I already mentioned in the urea test when we use the C13 urea. And this is very good because today's we can measure with the laser spectroscopy and giving the specific substrates such as the urea, lactose, fat, glucose, acetate with this C13, we can detect which, let's see, disease is associated with which problem could cause this. For example, H. pylori, urea breath test. Lactose intolerance, we can use the lactose. Or chronic pancreatitis, the fat absorption problem, the trialine, for example. Or malabsorption, the glucose, labeled glucose can be used. So this kind of isotope is helping for the GI doctor to evaluate, let's see, the GI function. As I mentioned, the D-xylose test is measured because D-xylose is not utilized in our body, so we cannot do anything about it. Absorb freely together with the L-xylose and immediately urinated out. So you can measure the urinated D-xylose and you can see whether how much or how many percentage of the D-xylose is absorbed from the intestine, and that can show directly the malabsorption problem. D-xylose usually can be absorbed in the small intestine, but not in the colon, for example, and not in the distal small intestine. So in the morbus Crohn disease, for example, it cannot be. Okay, inflammatory bowel diseases, that's the immune-mediated bowel diseases that usually the patient, they do have a spastic abdominal pain, diarrhea. It can be mucus or blooded-like, weight loss very commonly. In some cases, for example, in Crohn disease, the extraintestinal symptoms, some skin, eyes, or joint manifestation can be seen. Fistulas can occur, especially in the Crohn diseases, and in primary sclerosing cholangitis, for example, can occur or can be associated with colitis ulcerosa. The diagnosis, it's meaning that we do have an inflammatory process in the, let's see, the terminal ileum in the colon. And what it means that endoscope or rectoscope and biopsy should be taken. In the patient, we should check the inflammatory markers such as the CRP, for example, or cholecystokinin or procalcitonin can be checked. And in the small intestine, the CT enterographic can be, sometimes video capsule can be seen how this intestine, the internal structure looks like. And microbiological stool testing, usually in diverticular diseases, should be tested as well to see what kind of bacteria we do have this intestine. Now, let's see specifically this Crohn disease that is called ileitis terminalis. That's a granulomatosis inflammatory disease that usually involves the entire bile wall. However, mostly the ileum is affected. And the therapy, that's an immune-mediated process. So immune suppressors such as prednisolone or methotrexate or cyclosporine could be used. And the new area, let's see, the biological treatment, such as an antibody against the tumor necrosis factor, can be used in this patient. The colitis ulcerosa, that usually it's only affecting the mucosa, so not the all layer are affected, but this is continuous, and the rectum is almost always affected in this case. And the treatment can be some drug, again, steroid, azathioprine, or surgical treatment can be. Now, in this case, I think that's been the last case, 35-year-old woman. She has diarrhea, bloody stool for 3 weeks, started to have fever 4 days ago. And since the diarrhea became more frequent, 7 to 8 times daily, and contained fresh red blood, vomiting also occurred several times without blood, and not a coffee ground-like stool. In addition, she is complaining about constant abdominal cramping pain around the navel, and the abdomen is soft, palpable, without pathological resistance or defense. However, with pronounced periumbilical and lower abdominal tenderness, otherwise negative status, and look at the CRP level is very, very high. Colonoscopy, the rectum and the distal aboral segment of the sigmoid colon is moderately inflated. A couple of small ulcers are visible. Ultrasound, descending and sigmoid colon are edematosus, inflamed, and tender upon the pressure. Free abdominal fluid is not visible. Now, this is how it looks like. That's a colon. That's a healthy colon. And this is what we do have here. That's in a colonoscopy is showing that ulcerative colitis, acute exacerbation with this patient. And again, the treatment, IV hydration, pain management, steroids, and this aminosalicylic acid, what they are using it. The GI tumor, another important aspect of the GI tract, especially the problem that the long asymptomatic period can before it's manifested. From the if the esophagus, usually it's associated with dysphagia or weight loss. If you do have this tumor in the stomach, the loss of appetite, distaste for meat, weight loss, nausea, vomiting, bleeding, pancreas, epigastric discomfort, loss of appetite, weight loss. And jaundice usually occurs when the head of the pancreas is enlarged, and that's the Courvoisier sign in the previous seminar we did have. And thrombophlebitis migrans can be detected in this case. Colon causes chronic occult bleeding, so anemia. If a patient over 50, let's see, diagnosed with iron deficiency anemia, you always have to think about a colon tumor. And the changing in bowel habits, meaning that sometimes the patient have obstipation and sometimes diarrhea. Obstipation is due to the obstruction of the GI tract. And when the bacteria has more time to disperse, let's see, whatever we left in the stool, that makes the stool, let's see, fluid or more fluid. And the increased distendance of the GI tract causes an increased peristaltic activity, and diarrhea is usually following the obstipation period. And mechanical ileus can develop, and rectum usually manifested as a fresh blood in the stool. Now, how can we detect this occult bleeding? Basically, what we can use, and usually what they use in the lab, the Weber test, or the and another very fast test that they can record the hemoglobin, or not the heme, the catalytic unit that is detected by the Weber test. Immunological test is very good one because they can test directly the human hemoglobin. Now, this screening should be performed usually over age of 50, and with a rapid test. This is in Hungary, but colonoscopy should be performed as well. And you have to differentiate from the polyps and the tumor in this case. Now, very rapid test, and that's the hemocal test. And usually the heme is going to catalyze the an oxidative region. And this is the final product, be a color product of the red color. And however, this reaction is usually giving a false positivity if you ate too much horseradish, for example, or radish, or certain medications such as ascorbic acid, so vitamin C, or iron can be a little bit gives a false negative. A negative Weber test or hemocal test doesn't mean that the patient does not have any tumor. So usually if somebody has an iron deficiency, colonoscopy is always required to perform to exclude the tumor. Keep in your mind. Now, further test in the GI tumor, endoscopy, said biopsy taken, ultrasound, and CT staging should be taken, and some tumor markers such as a chorioembryonic antigen or CA19-9 should be measured, but mostly in those areas, if you don't see anything, any tumor, or before the operation. This is what we are going to discuss later on, because as a efficacy of the treatment should be checked by using a tumor marker. And if you do perform a test for this tumor marker before the operation, you see what was the level of the tumor marker, and after operation, it should be decreased back to the normal limit. If not, it meaning that we still have some metastasis or some other tumor left in the body. Okay, let's see another case. A 74-year-old woman. She has cramping bell-like abdominal pain for 1 month. In addition to this, the pain also occurred in the right upper quadrant. Nausea, vomiting also occurred, but without blood or coffee ground-like aspect. Bloats and has poor appetite. Recently lost about 5 kilograms. Had small amount of stool in the last few days, has diarrhea, and the gases are poorly passed. Stool was without blood, dark color or mucus, so no tarry-like stool was detected. Abdomen in the level of the chest, soft and palpable. There is no tenderness to pressure. The epigastrium is filled. There is a palpable green walnut-sized mass over the area of the transverse colon. Otherwise, it's negative. And the imaging, let's see, the abdominal negative radiography. Okay, so there was nothing. CT, however, showed the malformation and the locoregional lymph node alteration can be seen in the area of the transverse colon, and colonoscopy to reflux linearis, transverse colon, the endoscope is freely guided. Here, the lumen is almost completely obstructed and by a hemorrhagic hard tissue perforation, which has been biopsied. Further progression is not possible, and this is how it looked like. So it's completely obliterated. Let's see the normal column, and that was the adenocarcinoma, was confirmed by histological evaluation, and the treatment for sure, it has to be a surgical removal of the tumor. Okay, so this was the theory. This was the theory that we had about the GI tract.